Hello and welcome to an In Conversation With. My name is Emma Smith. I'm the project manager with Empowered Conversations, which is a project of Age UK Salford in the UK. Absolutely delighted today to be in conversation with Joe Gaugler. Joe, thank you so much for giving your time to share your research with us today.
Sure. Well, thank you for the opportunity. I'm very much excited to talk with you today. I certainly hope if we get through this presentation quickly enough, love to hear questions, comments, thoughts. Again, I really appreciate this time.
Brilliant. Thank you, Joe. If you haven't been to one of these before, welcome. The plan will be I'll give you a tiny bit of background on Empowered Conversations before we hand over to Joe for his presentation. And as Joe indicated there, we'll have some questions at the end. You'll have found where people have been saying, "Hi, I'm Judith from East Lancashire." That's where you write your questions. So drop them in there into the chat and I'll make sure, well, we'll try and get as many questions answered at the end of the presentation as we've got time for. So a little bit of background on Empowered. We empower families affected by dementia to live as well as they can. And we do that by delivering communication courses. So we have Empowered Conversations, we have Moving Beyond Words. We offer dementia-focused therapeutic support through Empowered Carers and based on the York University Caregiver Intervention. We do regular webinars like this, and we also have a couple of monthly groups, one around bereavement and the other one offering carers a voice to share at a local, national, and then a national and international level, in fact. I think that's all I want to say, Joe. So if I bring your presentation up, I'm going to hand over to you, if that's okay.
Yes, that'd be great. Thank you. Well, everyone, thank you so much for your time today. Very much appreciated. Again, as I had mentioned to Emma, I am so impressed with your work and your efforts in the UK and everything that you've done. And it's a great privilege and honor for me to talk with you briefly about some of the recent work we've been disseminating, certainly based on the New York University Caregiver Intervention, related to supporting carers of people living with dementia who live in residential care settings. And when I use the term residential long-term care settings, I'm referring to nursing homes in the US, assisted living facilities that have a memory care unit, those types of settings. And that's really the focus today. And, you know, I think another goal of the presentation today is to think about how to leverage different types of data in evaluations like these to maybe provide insights that otherwise wouldn't be apparent, particularly when we approach it from a more classical, highly quantitative perspective. And you'll see in terms of how I lay out the presentation and what I'm talking about today, how we've been kind of moving along that continuum. So I wanted to acknowledge first and foremost all of the families that participated, not only in this study, but in all of our efforts, both in terms of research as well as community outreach and engagement. We had many residential long-term care providers themselves who were willing to help and identify families across the US for this particular project I'm going to talk about today. I also very much am grateful for my project team. Robin Birkeland, Ellie Albers, Katie Luagi, Zach Baker, as well as others that really helped and worked on this project for several years that allowed us to successfully disseminate the work. Names here that I'm sure you're familiar with, certainly if you are doing the NYU Caregiver Intervention, Mary Middleman, who was a co-investigator on the particular project I'm talking about today. Mary and I have been working and worked for many years, where I actually adapted the New York University Caregiver Intervention for adult children in the state of Minnesota, which then led to this particular project, which has been built on an interest I've had for a long time. Transitions and dementia caregiving. How do families navigate those transitions? And most importantly, how can we help support families navigate those transitions? And dating back all the way to my master's thesis project, I've been very interested in institutionalization or residential long-term care entry as a key transition over the course of dementia, trying to better understand how families navigate that. The data, the quantitative data in particular, are publicly available. I provided a link here specifically for our randomized control evaluation, which I'm going to start talking about here. The trial is registered at clinicaltrials.gov. This grant was supported directly by a grant from the National Institute on Aging to me. And again, very grateful for that support. Also, and I think you're aware of this, I certainly shared this with Emma, is both of these papers, or more specifically, what I'm going to be talking about today has been published in 2 papers to date. One in Psychology and Aging, which just came out this past summer, and then earlier last year in 2023, the results of the qualitative analyses that we did on the residential care transition module. Let's start, and you've heard me allude to this a little bit already, but I don't think it should come as any surprise to anyone here at this presentation that caring for people living with dementia is not just a personal concern. It's quite frankly not just an issue that has health or psychological relevance to the person living with dementia or a care provider. It really is a issue, I would argue, of public health concern. It affects large proportions of populations, certainly in the US and certainly in the UK as well. It has inordinate effects on subgroups within those populations. For example, women. There certainly is an emerging basis of research of disparities related to race, ethnicity, those of LGBTQ identification, orientation. And again, a case I've been trying to make in my more recent work, and I think others in this area have, is really it is an issue of public health concern. When one really takes stock of not just this very large literature on the health effects, the emotional effects, the psychological effects of dementia care provision, but what does that really mean to us as a society? Certainly in the US, you can make a very cogent case that the long-term care system in the US rests on the shoulders of a vast unpaid network of individuals, primarily family members. And when one considers the insidious long-term trajectory and progression of dementia, that becomes even more an issue, because how long can we rely on that? How long can we rely on these unpaid individuals to keep providing year after year after year of care? There is some suggestion that, in fact, because of childbirth trends, because of a number of other sociodemographic trends, that in fact, older people with health needs will not have the same number of unpaid individuals to rely upon to manage their health needs. How are we going to offset that gap? Okay, this is where I think the work you're doing, the whole work of trying to develop dementia care interventions to determine, number one, their efficacy and effectiveness, and number two, determine their scalability and implementation potential, is so important. It has public health relevance. So because of its long-term trajectory, and again, if one looks at data, people living with dementia after point of diagnosis, particularly with Alzheimer's disease, are expected to live on average 6 to 8 years. But we all know that diagnosis still ends up happening fairly late in the disease trajectory. And I'm sure many of you work or know of people, I certainly do, where they have been caring for a loved one with dementia or a relative with dementia for 10, 15, 20 years. So it is certainly a long-term trajectory. And as I had mentioned, what I have been very interested in from a scientific perspective are those transitions that occur during the course of dementia, diagnosis, increases or changes in behavioral expression, needs for home and community-based services, bereavement. There's a whole series of different transitions one can point to that could influence the dementia care context. And again, one I've been very interested in is the residential long-term care entry transition. Close to half of nursing home residents, for example, in the US have a formal diagnosis of dementia. And quite frankly, if you start to factor in the number of people who have dementia that aren't diagnosed, that number probably looks more like 3/4 or more of people are living with dementia in these settings. We know, and again, there's a fairly good body of work, if not quantitative, certainly qualitative, that suggests that when a carer admits a loved one or a relative to a residential long-term care setting, that can pose a number of different challenges, ranging from adjusting to new roles in care. For a long time, institutionally, really honestly, even now, if one takes a look at the literature and considers it, often institutionalization, nursing home entry, it's treated either as a point of attrition in studies or actually an endpoint of a study. But we all know family care continues after that transition. Now, it might change in terms of its nature, in terms of the challenges and potential stressors that families experience, but care is still happening. And so, again, when we consider quality of care concerns, interactions with staff, etc., families are often still integrally involved. And so, what does that mean for them? If it does pose challenges, are there ways to better support them so they can navigate this transition? Presumably, not just to help family cares, but then also those that they're caring for to have a smoother transition into what's often needed residential long-term care. You know, an issue I've always had with how long-term care policy is formulated in the U.S., and perhaps it's the same in the U.K. and other countries. You can speak better to that than I. Is so often residential long-term care entry, nursing home admission is an outcome to be avoided, and it's an outcome to be avoided because of the significant costs it often poses to a variety of payers in the U.S., most often the public through Medicaid and other funding sources. But I've always felt that delaying or offsetting or preventing nursing home admission at all costs, is that really the outcome we should be striving for? Versus how can we help maximize the timing of that transition so it best works for the many people involved in that decision? First and foremost, the person living with dementia. Secondly, the carer. And then third, also the formal care providers, such as residential long-term care staff. Is there a way to maximize the timing of that transition? So when it happens because it's needed and it's the best possible option, versus the approach that, well, this must be avoided at all costs, or alternatively, making these types of decisions. And I think this is often the case in the US, making these types of decisions based on availability, maybe due to a healthcare encounter, where the full pros and cons of the decision aren't weighed appropriately. I mean, so that to me is the context. I think we're thinking of how can you best support families during this time. So the purpose of the residential care transition module, the prior points on the slide have already been made, was to do as follows. It was a 12-month trial. And our goal was to evaluate a psychosocial and psychoeducational program that we developed, again, based on many elements of the NYU Caregiver Intervention, as you'll see, but also an intervention that's delivered remotely, primarily by telephone, but potentially by video conference as well, for family carers who have admitted a cognitively impaired relative to a residential long-term care setting. So that's our broad goal here. We know that the transition may pose challenges for some families. Are there ways we can better support those carers during this particular transition? So that was really how we approached the development and eventual evaluation of the RCTM. So our hypothesis in our parents trial was as follows. We hypothesized that family carers who received the RCTM, when compared to those in usual care, so they didn't receive the intervention, would report significant reductions, one in stress related in general to care, but then also related to the transition itself, and then also depressive symptoms, really well-being. I didn't want to spend a lot of time going into this. The intervention itself and its evaluation was based conceptually in what's called the stress process model. That's where these terms, subjective stress, certainly psychological well-being like depressive symptoms, come from. But again, that was really what we had grounded our intervention in terms of its evaluation. So it did have a conceptual theoretical framing. We also had a number of secondary outcomes that we considered, again, much related to the transition, the residential long-term care setting context itself. Family caregivers' feelings of competence and self-efficacy, for example. But then also family involvement in visits for the relative after they've been admitted to residential long-term care. We had a number of variables that address what we called secondary role strains. A lot of these address perceptions of communication and relationship with the staff, with other family, with the care recipient after our LTC entry, for example. And then we had a variable called residential care stress, which again assessed overall how stressed was the carer related to having a loved one in a nursing home or assisted living setting. And later I'll provide more details on what these measures were. Forgive me if this is a very busy slide, but in a way it captures the complex design that we applied for the residential or the RCTM evaluation. This is called a mixed methods design, an embedded or experimental mixed methods design, in that In addition to collecting quantitative data, we collected a range of qualitative or open-ended narrative interview data from participants throughout the study. And I'll take you through this here. So on the left-hand side of the box, you see kind of the traditional randomized controlled evaluation we conducted. Individuals who enrolled in the RCTM were randomized blindly, and they either received the intervention or not. We followed and administered surveys to caregivers at baseline, pre-randomization, pre-intervention, and then at 4 months, 8 months, and 12 months. Okay, and you see there on the upper left-hand side the various measures we collected in the quantitative component, as well as the analyses we did as part of the quantitative evaluation. However, we also tried to collect robust qualitative data throughout the course of the intervention. So for those who received the RCTM intervention at 4 months, 8 months, and 12-month follow-up, we also administered what were called treatment review checklists. These were items that were developed for this study that, one, provided quantitative data on perceptions of benefit of the intervention. How was it feasible, acceptable? What did caregivers who were participating in the intervention, did they perceive the intervention was benefiting them? But in addition, we also had some open-ended items in those treatment review checklists to get us qualitative data about what about this intervention works or not and why. Okay, so getting more at this idea of process, how and why is the intervention working? Then in addition to that, after the intervention, we administer what's called a stratified purposive sampling procedure, where we identified people based on those treatment review checklists who really were enthusiastic and received the intervention well versus those that were more moderate in their receipt. And we stratified them in terms of, again, high or moderate or low perceptions of benefit. And then we conducted interviews with them where we did a semi-structured interview with them to get, again, a better sense of how and why is this intervention working. And we leverage that data, and we're actually still in the process of leveraging this methods data to get a better sense of the potential benefits and effects of the intervention, and particularly for whom and how the intervention is working. Okay. So what is the intervention itself, the RCTM? Again, you'll see some commonalities with approaches like the NYU Caregiver Intervention. So we applied, like the NYU-CI, 6 sessions of counseling, essentially coaching, that occurred during the first 4 months of participation. These very much were tailored to the needs of caregivers who were randomly assigned to the RCTM intervention, tended to cover a lot of different topics related to interactions with staff, stress, navigating multiple roles as part of the care experience, which in some cases were magnified if a loved one entered a residential long-term care setting, et cetera. If time permits, I'll actually show you a breakdown of what were the actual content topics addressed in those sessions. The study focused on those we considered primary or those who were most responsible for the care of relatives living with dementia in a residential long-term care setting. Again, counseling sessions tended to last from 1 to 2 hours, and they were primarily done over the phone. There were some instances where video conferencing was done, and that was an option for caregivers. But again, it was mostly done over the telephone. So again, the sessions were spread out where it was weekly for the first 3 weeks and then every month for the following 3 months. And then after that, again, very similar to the NYU-CI, ad hoc session counseling was available. So families could contact the counselors or coaches at any time if a need came up, if issues came up. And so that was used fairly considerably in the context of the RCTM intervention. We conducted a successful pilot of this project. It was roughly 8-9 years ago now, but that was around 2016, I believe, that it came out. And that was used as the basis for putting in this grant proposal, which was successfully funded to do a large-scale randomized control trial. So we had 240 carers who were enrolled in the study, randomly assigned 120 to treatment, 120 to control. It was admittedly a fairly homogeneous sample. It was mostly white individuals, women, which probably isn't that surprising for a caregiving sample. Most participants were married and fairly well educated. So we didn't have a lot of SES or socioeconomic status variability, unfortunately. On average, age was 63. Close to 2/3 of the sample were adult children of relatives living with dementia. We did provide contact for the control group. So initially, we asked controls if they wanted resources at baseline. And then every 4 months, we did a check-in call with controls to get a sense of how are they doing? Do they need any resources we could refer them to? So it wasn't as if those in the control got absolutely nothing. They were able to contact and get in touch with, actually our transition coaches did reach out to controls to just determine if there were any resource needs that they could be that they could connect people to. I think we've gone through this, but the date of data collection was from December 2016 through May 2021. And clearly, as you can see, we continued collecting data throughout the pandemic, which actually led to a couple of spin-off studies. I should have cited them here and I didn't, where we actually created a supplemental data collection module about the COVID pandemic and how that affected family members and how did the intervention operate during that time. One of the benefits of the intervention, and of course we were lucky in this regard, because it was delivered remotely, we could continue with the intervention and the data collection, and even in some cases limited enrollment. I believe our last participant was enrolled in early 2020. So for the most part, we had enrolled most of our sample before COVID, but nonetheless, we could continue delivering and administering the intervention throughout the pandemic. We already talked about what the primary and secondary outcomes were, so I won't spend a lot of time on this. Here you see the examples of some of the validated measures we use. Now, if you would want me to provide you specific citations of these measures, get in touch with me. I'm happy to do it. I didn't want to busy up these slides too much or spend too much time. But this gives you a sense, again, of the different sub-measures we use to get at subjective stress as well as depressive symptoms as well. These are all well-validated measures and have been used across studies. However, you'll see in the conclusion, are these really the measures that capture what's going on for carers post-institutionalization? Many of these measures were developed for caregivers and validated for caregivers in those situations, but my feeling is, and I would actually say this is an issue across dementia care science, is are the measures that we've traditionally relied upon, are they really capturing what's happening for carers? And are they allowing us to understand how these dementia care interventions are operating and working? My sense is not really. And this trial was one example of that. Again, you see some of the other examples of the measures we used here to address competence and self-efficacy. Although I will say this, for those of you in the literature and looking at the short sense of competence measure, to be honest, when I looked at the items of that measure, I really wondered, does it really get at competence? And we don't have time to go in the SSCQ. It is a widely used measure, but in looking at the items, I didn't get a sense it really addressed competence. It kind of was getting at something else. So, but nonetheless, we included it here. We did have a more, I would say, face valid measure of self-efficacy that we also applied. And then here, a bunch of measures, most of these developed by Carol Whitlatch, who also was a co-investigator on this project, to get at some of the key issues as they pertain specifically to navigating residential long-term care for families. Issues related to staff support and communication, interactions with relatives, staff, and other family members as it pertains to a relative's institutionalization, assessments of how well the carer themselves, as well as how they perceive their relative adjusting to residential long-term care, as well as upset. Well, I mean, I guess one benefit of not finding any direct effects is I don't have to spend a lot of time showing you fancy slides. I mean, essentially, when we looked at the traditional direct effect of the intervention, treatment versus control across all of these outcomes, we focused at a 4-month time point because that was when the formal sessions were completed, as well as at the conclusion of follow-up, which was 12 months. We actually found no statistically significant differences. I mean, there's no way to gussy this up. I mean, pardon the expression, but that's really what we found in terms of direct effects. Now, one of the things we did do, and now I want to really argue here and caution that what I'm presenting to you now was really the result of post hoc analyses, meaning that these were not intended as part of the original analyses. It was very much exploratory. So all these further findings have to be taken with a grain of salt. And we were very clear about this when we reported. But nonetheless, we wanted to explore and determine at a post hoc basis, an exploratory post hoc set of analyses, were there some other potential variables that were moderating the effects of the intervention, meaning that were there subgroups, were there situations where some of the participants might have actually been benefiting beyond just the overall main effect analyses that we did. And we started looking at some things. Pardon me, these are just the results of the secondary analytic outcomes. We did see some strange results. These weren't these weren't very large effects, but in the treatment group, we found that caregivers actually were reporting more negative staff interactions at 4 months. And then over a year for the overall sample, you saw actually some negative outcomes of intervention participation, which didn't seem to jive very well with what we were seeing in the qualitative data, or in general, what we saw with even some of our post hoc analyses, which I'm going to share with you now. So one of the moderators, or the set of moderators we considered, were as follows, and we did this for a couple of reasons. One was we enrolled people regardless of how long their relatives were admitted to a residential long-term care. But in doing so, we actually stratified the sample. It was called randomized stratification to ensure balance of the sample. So we actually had a variable for people where they had their relatives in the setting less than 3 months or over 3 months. We actually incorporated that as a moderator of treatment effect, almost like an interaction term for those of you who are familiar, to determine did time since admission really influence the effects. Similar with employment, there was imbalance in the randomization, where I believe either the treatment or control group were more likely to be employed caregivers. So we also incorporated that as a moderator too. Then finally, bereavement. And as you can imagine, in this sample, bereavement was extensive amongst participants. Many care recipients passed away over the 12-month period. So we also included that as a potential moderator or control to see if that also further influenced the effects. Oops, sorry. So what did we see? Treatment groups whose relatives were admitted to long-term care more recently were more likely to indicate reductions in depressive symptoms initially in participating in the RCTM. So over the first 4 months of participation, for those who received the intervention and were caring for relatives who had been admitted fairly recently to long-term care, were more likely to indicate increases in well-being or reduction in depressive symptoms over that critical first 4-month period. Now, it is important to note that this evened out with others over the 1-year period. But even so, it suggests some immediate potential benefit of RCTM for those carers who, again, are really dealing with the more immediate potential effects of admission. This is just a graph of the effects. I think a question, if one is skeptical, is, well, yeah, Joe, you found statistically significant. Are they really meaningful? That is arguable. But nonetheless, it is something we found statistically that's important to note. And you can kind of see that some of the changes here that we were able to identify, at least graphically. So when looking at employment, we found that employed caregivers in the treatment group, they initially indicated increased burden over the 4 months, but over the full period, these employed caregivers then also reported increased self-efficacy too. Starting to see pretty nuanced effects, right? Complex effects and trends, but probably is not that unusual for those of you that are actually working with families. If you start providing them services and support, particularly support of this kind, if they're employed, that could be challenging for them to navigate. They're employed, they want to visit their loved one, now they're participating in this study. That could raise burden for them, at least initially. However, when they actually incorporate the skills, the learnings of the intervention, it may have an effect over time too. And so that was what some of these post-hoc analyses allowed us to maybe provide some very, very preliminary insights into. Okay. And then finally, for bereavement, we found that when we actually removed post-bereavement data from participants, it didn't impact any of our outcomes. It did impact some of our post-hoc analyses in that when you removed post-bereavement data from the analysis, differences for depressive symptoms over the first 4 months or the 12 months for those recently admitted relatives, basically they washed out. But that being said, for many of this subgroup, I'd have to look again at the data. And we're getting really complex. We're starting to slice up the data in a lot of different ways. But I'd have to actually see for how many of them actually experienced bereavement data in those earlier stages of the intervention. I'd have to look at that more carefully. But again, one thing we did find is when you throw out all the bereavement data, now remember, we still collected outcome data on people after their loved ones passed. We made sure to keep collecting that data. This was actually done at the behest of a reviewer in the journal article, so we felt it was important to report that. All right, so really quickly there, I gave you a quick overview of what we found in all of the empirical data, and that was all published in that one paper in Psychology and Aging. But recall all the qualitative and open-ended data we collected. We had the opportunity to further dive in to determine what is it about this intervention that participants in the treatment group seem to value. Because what we were finding, and even informally, just looking at qualitative responses and the semi-structured interview data, in fact, the caregivers who participated in the intervention were almost universally appraised the intervention as beneficial. And so what accounts for that mismatch between finding really largely no direct effect in the quantitative data? So we conducted this robust qualitative analysis of all of the available qualitative data. I'm not going to read it. I mean, I think we just reviewed this, but this gives you a sense of the types of qualitative data that were collected. Again, we collected open-ended data at the 4, 8, and 12-month surveys from those in the treatment group. And then further, we did interviews with 30 participants in the treatment group amongst those who received the intervention well versus those that were more moderate or tempered in their assessments of intervention benefit. Okay. We created a 21-item Likert scale to get at some of the quantitative data about how participants perceived the RCTM. This is what we call a treatment review checklist. I don't think we'll present the data here, but honestly, most of the participants and all the items, almost all of them averaged 4 or higher on all of the assessments of the various aspects of the intervention. We talked about the semi-structured interviews. Again, these were perfectly selected based on the Likert scale, average of the Likert scale items from the treatment review checklist. We basically found the best way to do it is those who either reported over 4, which were many, versus those that reported under 4 on average. And then we also further tried to purposely identify caregivers as they varied in gender, relationship to the care recipient, were they adult, child, or spouse, and then again, time since placement in long-term care to give us a better, wider sense of what were the overall appraisals of the intervention benefit. We actually did a fairly intensive qualitative analysis, a thematic content analysis. Multiple team members were involved in doing this to get a sense of what about the intervention, what aspects of it, why or how did the intervention benefit participants or not. Oops, sorry. So what came out of these qualitative analysis I thought were quite interesting. One were a series of mechanisms of benefit. When I say mechanisms of benefit, I'm talking about essentially aspects of the intervention that seem to drive potential benefit for participants. Again, getting at this how or why. Why did the intervention work? How did it work? And by doing the qualitative data analysis, it allowed us to start to pinpoint potential mechanisms of benefit. And then importantly, and this kind of gets to that point I made earlier about outcomes. You know, again, initially when we did the empirical quantitative evaluation, we relied on outcomes that were validated, standardized in the literature. However, the qualitative data seemed to suggest a series of other outcomes that might be worthwhile to pursue in subsequent analyses to get a better sense of these are the outcomes that the intervention really was influencing. Not necessarily the standard depression, burden, stress, et cetera, but maybe more granular, specific outcomes to consider. So really the main themes, the main mechanisms of benefit really came down to 2 large themes. And there's some pictures here and images that get at some of the sub-themes, but let's really focus on the 2 aspects. One was the fact of how the RCTM directly provided, 1, information and education about dementia and residential long-term care and dementia care in those settings. And 2, it provided key strategies for communication and other key aspects of need that dementia caregivers could address and then apply in their own day-to-day care situations. That was one reason why participants felt the RCTM worked for them. Then secondly, and specific to the intervention itself, was the supportive relationship that was established with the transition coaches. Feeling that someone listened and understood what was going on. So that was a key thing that came up again and again in the qualitative findings, as well as availability, and again, providing key information and supports that in many instances families didn't necessarily have access to, or didn't feel like they had access to prior to participating in the intervention. We captured this in the qualitative, and this was not easily captured in our quantitative data. Okay. again, when you look at some of the outcomes here, I should have asked my team members to give me a better sense of what these images actually meant. But I think in a nutshell here, what we're getting at is really, in order for us to better capture the effects of some of these types of interventions, these multi-component dementia care interventions, we likely have to go beyond what's measured in a standardized validated fashion, or maybe create new measures to better capture some of the person-centered aspects of how these interventions work. Just like with the NYUCI, even though the NYUCI has maybe a more robust tradition of showing effects on outcomes, just think about when you talk to carers and those who care for loved ones with dementia. I'm sure they'll talk about burden, they may talk about depression, but they talk about a lot of other things too. And that happened in the RCTM and the qualitative data as well. And so I think the upshot of this and all of this body of work is, one, the importance of incorporating qualitative data collection alongside quantitative data to give better insights as to how and why an intervention works, number one. Number two, to provide insights as to better outcome measurement. We really need to continue moving in this direction as a field in terms of not only researchers, but I would argue also as practitioners and providers. And so how can we better capture the lived experience of dementia carers in ways that really help demonstrate the potential benefit or effectiveness of these interventions? I think many of us know and get a sense from talking to carers, they work. They work, but how can we better show the value of these types of interventions? And as a field, I don't think we've done a good enough job in doing that. And I'm the first culprit. I'm saying this not necessarily to criticize anybody. I'm criticizing myself and my own work. We have to do a better job. And by extension, I think you can make an argument, so does the rest of the field, quite frankly. One thing, and I didn't show much of this here, but the intervention, you could make an argument when looking at trials like this is that, well, you didn't show any effects because the intervention wasn't delivered the way it was intended. People weren't going to sessions, they were taking too long, etc. What we did find was, in fact, the intervention was delivered with a high degree of fidelity. Almost all participants completed their 6 sessions in 4 months. We had a very robust fidelity or adherence data collection approach where we collected amount of time, when sessions took place, with whom, what was discussed. And again, we're actually analyzing all that through what's called a process evaluation. And I'll give you some insights. Again, we're just getting ready to submit the process evaluation paper. But what we found when we looked within treatment group caregivers was really the benefits of the ad hoc sessions. Now, again, there was very little variability in the number of formal sessions participants engage in because they all engage in the same amount. They almost all did the 6 sessions in 4 months. But there was a lot more variability in how often carers utilize the ad hoc session benefit of the RCTM. And what we found was, in fact, carers who utilize those ad hoc sessions more were more likely to benefit from the intervention on some of those measures we showed earlier. Okay. Again, I think I've covered a lot of these points. This last point is pretty interesting, and it's something I've been thinking a lot more about. And, as researchers, we care so much about the p-value, getting it less than 0.05. But do any of these results really mean anything? Are they clinically meaningful? Are they meaningful to the day-to-day lives of carers? And I would make an argument that when we look at not just dementia care research, but dementia research in general, the effects, for example, of new therapies emerging for Alzheimer's and dementia, as well as all of these interventions we've been testing, do we talk enough about clinical significance? Do we have measures that actually show clinical significance? Meaning that if you see a change in this measure for a certain amount or certain metric, is it meaningful? And that's, again, thinking and considering and contemplating these findings is something I think we need to emphasize across all of our research, as well as our practice and service delivery too. Again, one thing I think that was very helpful that you even saw in the quantitative outcome analysis was the need to determine context. We all know dementia, I would argue Alzheimer's disease, is very much a disease of context. We certainly are aware it not only affects the person living with dementia, it affects the carer as well. But those care situations and contexts are happening in very, very diverse care environments, aren't they? Homes, number and of other family members or friends or others who are involved in the care situation, the relationship quality that carers might have with others in the care situation, the relationship quality carers might have with staff. All of these things obviously can play a role into whether an intervention like the RCTM is going to be beneficial. We have to understand, and maybe even in an a priori fashion, test and examine and consider the context, the levels of influence that these interventions operate at beyond just the carer themselves. Okay. Again, and I've mentioned this before, the value of embedding qualitative data into traditional quantitative data collection approaches, I think, is so critical when we're dealing with these complex dementia care interventions that often are working with fairly heterogeneous carers or heterogeneous care situations. Okay. This is why, and I would argue why we were able to, I guess, for lack of a better term, salvage positive aspects of this intervention. I'm of the belief, regardless if you do an intervention and it works or not, for the betterment of science, for the betterment of translation and implementation, those results should be published, and the researchers should really describe why or how they think results emerge or not. But when you have qualitative data, it gives you additional sense of why and how an intervention is working. And as you can see here, it was employed to fair effect to determine what was going on with this particular intervention. The other thing we're doing, and we're just pulling together the results now, and I have to present these next week, so they should be done soon, at least in slide format, is one of the things we did is you saw those qualitative findings, mechanisms of action, other potential outcomes. What we did is we're actually going back to the quantitative data, and we're looking at the measures and particularly specific items. That's not ideal. That's not the greatest way to measure something, but what we want to do is go back and, based on the qualitative data, does that actually inform whether the RCTM was indeed effective, but for a more granular or different set of outcomes than we originally had tested? In some of our preliminary analyses, and again, it has to be interpreted with great caution. It's post hoc, a lot of analyses. I mean, it could be basically, I think in this case would be a type 2 error in that, you do so many analyses, the chances of you finding something statistically significant goes up, right? But that being said, we're starting to see certain patterns where, in fact, the qualitative data was giving us insights as to the intervention was actually potentially working for these sets of outcomes. And it may actually inform the development of new measures that could better capture, again, the effects of these types of interventions, okay? I think I've been talking about this quite a bit here, and I want to save some time for questions, our last 15 minutes. But hopefully you get a good sense, I think, of this intervention, what we tried to do. But again, how leveraging multiple methods and mixed methods allowed us to, I think, take interpretation and inference of this intervention and its benefit to the next step, and maybe even better inform if this intervention was to be deployed. If I gave it to you at the UK and you wanted to use it, you can start to see by doing some of these moderator contextual analyses, it might give some insights. For example, well, maybe this intervention is best for those carers who have just admitted a loved one to a nursing home. This is when it works, but it can be done in a time-limited fashion, maybe for 4 months or something, which in a way is a good thing because it helps maybe create a more scalable, efficient intervention model, and that's good. Or should it be targeted maybe to those carers who really are being burdened with multiple roles, like employment, visiting, navigating resident, again, targeting the intervention. Again, some of these analyses might provide some insights to that effect too. I think I'm right on time here, so I wanted to leave at least 15 minutes for questions and some additional people to thank here. If you do have follow-up questions or want to engage with us or me further, I provided some other accounts to engage me as well as email, of course. But Emma, why don't we turn it over to questions now, if that works for you?
That's fantastic. Thank you so much, Joe. And yeah, you posed some really interesting points at the end. Pauline has got straight in there and she said, oh, wait a minute. I'm going to have to go back up.
Okay.
They're getting excited. So Pauline, good. So she said, great to see qual research again showing the nuanced effect of an intervention. Any information through the qual data on things participants may have found less helpful about the program?
That's a great question. That's a very good. It is in our qualitative paper. I probably should have provided that to you in terms of what were some of the issues. I just don't remember. I am so sorry to say that. I'm going to pull up the paper now while we go through some of the other questions, and
Oh,
I'll get back to that, or if someone else can. But
no,
no,
don't.
there were certainly issues with the intervention, and those
Pauline,
did come out with
Pauline
qualitative.
said, Joe, don't do it now. Pauline said, don't worry, she'll read it.
Okay, sounds
Don't do it
good.
now. Stop doing your
Yeah.
homework now. We're all watching. Don't do it now.
Okay, no, it's no problem. But thank you so much. So,
Um,
yeah.
and she asked another question: will the quant results, i.e., no effect, prevent rollout or funding of the intervention, despite the positive perceptions reported in the qual data? Do you think?
Well, that's a really good question. If one approaches this from a traditional perspective, it could. But that's where I would argue, and I think you probably would all agree, for those, and particularly if you're in the field, you're working with carers. I mean, when a decision is made to adopt a program, to some extent, one wants to know, is it evidence-based or maybe even evidence-informed? And, a good example is the NYU-CI. You could argue it certainly is an evidence-based approach. But that doesn't necessarily mean the intervention is going to be scalable. It's going to be implemented appropriately, or can be implemented in a given organization or with a given community. And so what we tried to do with these analyses, and you heard me say this, is I would argue that should this be an intervention, a standard of care? No. And I think we can make that case pretty clearly, even with the qual data. I mean, I think it would help people, but like, how would you feasibly incentivize someone to deliver this? That being said, when looking at the moderate, the contextual analyses, particularly, I would argue for those carers who have recently admitted someone to a nursing home, a loved one to a nursing home, and the fact that you could deliver this intervention fairly cheaply and remotely gives insights as to how you could scale and implement this intervention. So if someone came to me and said, we have to do something for our families, we want to do something for our families in this setting, what would you suggest, Joe? I would argue packaging the RCTM in that way, and then offering as needed ad hoc sessions. And this is a type of intervention I think could probably be delivered by a range of professionals. And so that's another, I think, that's potentially another argument for its potential implementation. But it's a good question. I think traditionally, if you took this and put it in a meta-analysis, what would a meta-analysis or scientists do? They would ignore all the contextual data. They would just look at the main effects. They would look at the means. They would take those, extract those, and plug them into their meta-analysis. That's, in fact, how many meta-analyses have been done with dementia care interventions. It's why, if you look at a lot of meta-analyses, they tend to be very modest, if that, in terms of showing effectiveness. But if you really dig under the hood of how those meta-analyses are done, there are major issues with them, I would argue. One being that for many of these multi-component interventions, how do you really classify them? We actually did a study to this effect, and I think it was 2016, where we actually did a meta-synthesis where we looked at all the meta-analyses done at the time in dementia caregiver interventions. And one of the things we found I think maybe you wouldn't be shocked, but we were, was the lack of consistency in how interventions were classified across meta-analyses. So take the NYU-CI, for example. In one meta-analysis, we call a multi-component intervention. In another, it's a psychosocial intervention. In another, it's called another thing. And so when you try to actually get a sense of what interventions work for dementia care, you really can't get a good sense from looking at the literature and looking at these meta-analyses, which is traditionally how the adoption of many evidence-based programs and how they're paid for is done.
Thanks, Joe. Right, we've got 10 minutes. Let me see. Phil said, I like the focus on the qual data. Did you look at the impact of ameliorating feelings of guilt and ambivalence in the family caregivers?
That's a great question. We actually did a study of guilt just as a descriptive study that came from these data. And much of that came from a qualitative perspective. We did not include guilt as an outcome here, in part because of our conceptual framing. Honestly, guilt did come up in the qual data. So, Phil, you raise a good point. Clearly, that probably in retrospect should have been an outcome we could have considered. And, I would go one step further, and again, gets to this post hoc analysis. Guilt probably is most resonant, again, for those carers who are recently going through this. Over time, many carers, they've adjusted to the point where they don't feel the sense of guilt. They're probably dealing with other things, maybe logistics or other issues related to having a person in residential care, long-term care. Again, it's not universal. I know that. Many carers struggle with this for many, many years. But my sense is it's that targeting this type of support for those that are just going through this is probably where we would get the most benefit. And guilt would certainly be something that probably would have to be addressed.
Thanks, Joe. What a question I had. I mean, you were delivering this during COVID.
Yeah.
Like, that was an extreme situation for families affected by dementia. So that in itself would have had a big impact on your results.
Yeah, I mean, when we look, it's interesting when, again, and it's consistent and parallel with what I just showed you for the overall trial. When we looked at the quantitative effects of the RCTM during the pandemic, we didn't see that it had any demonstrable statistical benefit. But again, we also did a qual analysis, and we had a number of open-ended items as they pertain to COVID-19, and it became more evident there. And it certainly was evident in talking to some of the transition coaches in terms of the types of calls they were getting during that time. Obviously, as you can all imagine, I mean, families were going through significant challenges during the pandemic, and using the transition coaches as a source of support during that time was highly valued. But again, we keep coming against this wall for whatever reasons, and maybe it was due to some of the initial measures we tested and included in the quantitative element. We just weren't seeing a lot of movement with the intervention delivery. There might have been other reasons to the design, but again, my sense is I keep coming back to this. I just don't think our measures were capturing the person-centered nature of the intervention. And so how can we better get to that? Many of the interventions we deliver are tailored. They're person-centered. They're based on the needs of who reaches out to us. We deliver, support program services based on the needs of people we reach. We should develop outcome measures that are similarly person-centered, not so standardized that they're not necessarily addressing what's relevant to our participants or clients or who we're working with.
Yeah. We faced something similar in our RCT, Joe, and we've come up with sort of similar conclusions. That's what we need to do to be able to really capture the difference of the intervention. I'm interested about the ad hoc. I don't think I've had any more. Have you got any more questions, you lot? I don't think you've given me any more. The ad hoc sessions that people could have with coaches. So, obviously I have my 6 sessions over a 4-month period, but then I get my ad hoc. So how did you, I could phone every week with my ad hoc. Was that how it was? So, I might be a weekly call to the coach, and other people might use it less. How did you measure that, and how did that sort of impact on the results?
Yeah. So basically, I can give you some data on this. Again, we're just compiling this for our process evaluation. So the average number of ad hoc sessions across the treatment group was 6, but there was a wide variety. The standard deviation was like 5.7. So in some, we had the range was really from 1 to 23 sessions, where again, you had some caregivers or participants using this quite a lot during the remaining part of the project, where some didn't use it barely at all. On average, the ad hoc sessions lasted around 41 minutes, but again, a wide range, ranging from 14 to 86 minutes. So in some cases, some of the ad hoc sessions were actually close to 2 hours. There was a lot of variability in terms of the ad hoc session usage, Emma. And in terms of what was addressed in those sessions, it ranged. It kind of paralleled the intervention content itself, dealing with emotional support, how to help address relatives' behavior, promoting communication. Those topics were similar to what was brought up in the main sessions, but they ended up continuing in the ad hoc sessions as well. So, for example, in over half of the ad hoc sessions, emotional support was the focus of the contact. In a quarter of the sessions, it was relatives' behavior, and another 26% promotion of communication. Again, remember, and often the ad hoc sessions were dealing with multiple issues at once. Problem solving emerged a lot. In a third of the sessions, it dealt with facility issues. So you kind of see the picture.
Yeah. And I almost wonder if, because it is over a year, and you talk about the move into full-time care as a transition, is there another transition that happens during the study as well? So, somebody's living in a care home for a year. Is there a reduction in their ability to communicate using words, and then those ad hoc sessions are sort of utilized to support caregivers around that?
Yeah, I mean, we did not use that type of, very adaptive design in this particular project, but you could certainly see that happening. One other transition clearly that was happening was bereavement. I mean, that was a big one in our particular study. The majority of carers had their loved ones pass away during the course of the study. Again, that didn't seem to affect the outcomes in general in our main outcome analysis, but that could be a source of participants that could require additional analysis, and hopefully a student sometime in the future will do that.
Right, we're in our last 3 minutes. So if you have another question or a comment for Joe, please get it in the chat now. Otherwise, he'll go and we'll miss that opportunity. But I think we can probably email him. It's really interesting how you sort of started the talk talking about transitions and how interested you are around sort of the support around transitions, because that's very much how we frame our work over here with Empowered. So that felt like a real synergy when you were talking about that.
Yeah, no, I agree. I mean, I've done some work in the past, and this is over 20 years ago now, but one transition I was always very interested in is onset of caregiving in dementia care, which we know often begins well before a diagnosis, sometimes even begins before, could be in some cases begins before issues are even recognized. How do you assess that? How do you measure that? And how does that onset transition actually influence outcomes? And one of the things I found in those initial studies were when caregiving actually began at the point of diagnosis or after, those dementia carers tended to indicate much more challenges over a 3-year period, and were more likely, I believe, to institutionalize their loved ones than those who I argued kind of more gradually transitioned into care responsibilities. They were providing care for some period of time before even a diagnosis occurred. I thought that was an interesting way to consider transitions, and also interesting when we think of how we deliver services, and a big emphasis is always identifying the carer, like formally who they are. But how do you also take into account what is often happening in real life, which care has actually been being provided for a long period of time, and many people don't even recognize that. But how are ways to, again, identify those that might be most at risk for these outcomes, which, again, I would argue are those who have these more abrupt transitions.
Amanda, she's put a massive question in the last minute. Thanks, man. When you say the bereavement didn't make much difference, was it explored how many went on to need complex grief support? I'm thinking, could it be the case that people who are supported during the acting role, they might not then need complex grief support? Okay, so actually, yeah. Did you dig into that?
We didn't, as I mentioned, we have not done much sub-analysis on the bereavement group. The one way we could do that, Amanda, would be to actually, I would probably first and foremost look at the specific coaching notes. And again, the coaches took very detailed notes of every session that they did, is taking a look at those notes, but those notes for that group of carers, let's say immediately post-bereavement, to determine and see, were these issues of grief and other things being brought up? As I had mentioned, we did do an analysis of grief more generally as it related to RLTC entry, and that certainly was coming up. Perhaps it was also coming up even more so in this bereavement subsample. Unfortunately, we didn't have any good empirical measures of grief, but that would probably be the way I would argue one could take a look at these data that we have to get a better sense of the bereavement situation. I have a colleague of mine, Zach Baker, who also worked on this project. He's very interested in developing support models for those caregivers, dementia caregivers post-bereavement. It may be something I'll bring up with him to see if he or one of his students are interested in looking at it. So,
well done, Amanda. You've given Joe some more work. So, Joe, on behalf of us all, you've got some lovely comments there. Everybody's saying thank you so much for your time today. Thank you for sharing your work. It feels like this is our first conversation, and I really hope, Joe, that we can carry on having conversations.
Absolutely. Again, anything I can do to support what you're doing, let me know. Really thrilled to have this opportunity. Congratulations on all the great work you're doing. And again, if we can ever be of help, just please don't hesitate to reach out.
Oh, Joe, you've opened a door that you don't even know about. Thank you all so much. So we're going to take a pause from our webinars until the new year now. So thank you everyone for coming along. And Joe, I'm going to post this up on YouTube, so then we'll be able to share it out to a wider audience.
Oh, good. There. Wonderful. Wonderful. Yeah. Thank you. All
Amazing.
Right.
Well,
hopefully I didn't embarrass myself too much for YouTube, so that's good. Thank you, everybody. Congratulations again. Let's stay in touch.
Brilliant. Thank you. Take care.
Bye, everybody.